Welcome, everyone, to today's webinar. I'm Anuja Vaidya with Beckles Hospital Review. We will begin today's webinar with a presentation, and we'll have time at the end of the hour for a question and answer session. You can submit any questions you have throughout the webinar by typing them into the Q&A box you see on your screen. We look forward to hearing your questions. This session is being recorded and will be available after the event. You can use the same link you used to log in to today's webinar to access the recording. At this time, I'm pleased to turn the floor over to Ben to begin today's presentation.
Good morning and good afternoon, everybody. My name is Ben Moore. I'm the Chief Product Officer of PerfectServe. By my background, I've been doing product management for roughly 20 years, and 8 years of those have been in the healthcare IT domain, specifically with communications. Before we get started today, I just want to thank everybody who joined our webinar and all our healthcare system partners that are on the front line right now with COVID-19. I just really want to emphasize that you all are the reason for doing what we do. My entrance into this industry is a very personal one. My daughter was born prematurely in an emergency manner with an emergency procedure, and both my wife and daughter were in the hospital for over 8 weeks. During that time, I saw how poor communications between clinicians can put patient safety at risk and actually put my family at risk. And it's for that reason that I started a company called Telemedic. That company is now part of the PerfectServe family. And I'm pleased to present with us today, we have Dr. Nick Patel. He's the Chief Digital Officer of Prisma. And I've had the pleasure of knowing Dr. Patel for quite some time now. And Dr. Patel, I just want to echo what I said to the attendees today, which is a huge thank you to yourself, your team at Prisma, and everything you're doing for us in these challenging times. And I really do appreciate you taking the time to join us on the webinar today.
Thank you, Ben. It's great to be here. Great to hear your voice. I hope everyone is well on your end as well. Just to give a quick background on myself, I'm a practicing internal medicine physician for the past 17 years. Currently serve as Chief Digital Officer and Vice Chair for Innovation and Clinical Affairs at Prisma Health, where I help lead digital health and focus on patient-provider engagement to deliver frictionless care. I recently also was made responsible for operations and fiscal sustainability for the largest department in our medical group, the Department of Medicine. Prisma Health is the largest, most comprehensive not-for-profit hospital system in South Carolina. It was formed about 3 years ago after Palmetto Health and Greenville Healthcare System merged to form Prisma Health. We span over 50% of the state. We have 18 hospitals, 30,000 team members, 330 ambulatory practices, and 45% of South Carolina live within 15 minutes of one of our locations. We're also the largest private employer in the state. Ben, the first time you and I met, your story really resonated with me, and it came through with your passion and how the technology worked, that you definitely used a personal experience to develop the solution. And my story is very similar in that regard too. Life loves to throw curveballs at us, and we're all going through that right now. And no one is immune to it, doctor or not. I remember August 10, 2005 very, very well. I had just finished residency and I was working as a hospitalist. I came home and my wife and I were going to take one final trip to Charleston, South Carolina, to spend the weekend there before the OB had told us to limit travel. But as I was packing the car, my wife broke her water 8 weeks prior to the due date. It seemed like my training kind of took over and I tried to be calm, but at the same time, my brain was just going wild with what could be wrong. Luckily, I had the number of our OB doctor, and she answered, and she immediately told us to come to the hospital. And my wife was in bed rest for 2 weeks. but they had given her medications to stop the contractions, and that also made her blood pressure plummet. And I remember one night having to put her stretcher with her head down, her feet up, before the nurses could come help me. And then eventually it was decided upon to go ahead and move forward with birth. And he was born on August 19, 2005. Everything looked great. I was the first one in the room asking what the APGAR scores were. I was already being competitive as a father for my son. And, healthy looking boy. And they whisked him off to neonatal ICU, as they do when you're born that early. Later found out that they put an oral gastric tube in the newborns for neonatals, and it got curled up. And we realized why my wife actually had broken her water so early, and that was because my son ended up having what's called a TE fistula, or tracheoesophageal fistula, where, during as you get to your due date, the trachea and the esophagus separate, but in his case, a small section actually remained connected. So if you were to feed him, that food or liquid would go into his lungs. So immediately, a lot of things started to happen. A lot of people started to come to us, the GI doctor, pediatric surgeon, the neointensivist, and all these conversations started to happen around coordinating what would be next steps for my son, who first needed a G-tube placed in so he could feed him through his stomach. And then he eventually, day 2 of life, had to be taken to surgery to fix the issue. Fortunately, he had the most common type, which was very easily repairable. And then eventually came back to neonatal ICU, where he spent another 6 weeks. And I just remember going through that, and as a fresh out of residency physician, trying to see patients at the same time, but trying to coordinate care and making sure that I knew what was going on. And I remember just trying to get in touch with people is very difficult. Even so, as someone on the inside, it was all about paging, finding that pager number, finding out who's on call, who's the GI doctor, who's the pediatric surgeon. And I could also see at the same time the frustration of the nurses having to try to figure this all out. And back then, a lot of this was on paper, and even the operators worked off papers based on, the different divisions that will let them know who's on call. And I got to see that, and I used that, as my mantra to try to improve the patient experience. Because as a parent, not a provider at that time, thinking about all the steps that I had to go through and the advantage that I really had being an insider, being a provider that others didn't have. And so when we think about all the digital solutions that we're putting out, when we start to think about new technologies like in communication, it starts with the problem that we're trying to solve and how we need to work towards efficient, seamless workflows so we don't delay care and we provide that best care that we can to our patients and our loved ones.
Nick, I really appreciate you sharing your story with everybody. And as you and I know, I've heard that story before, and it really touched me. And it's funny how dates stick in your mind, right? Mine was August 29th, 2010. Very similar story where paper and slow communication caused my daughter to almost, she got caught up in the birth canal because diagnosis of placenta previa wasn't properly shared on a shift changeover. And I was dumbfounded how such a simple thing should have been and could have been communicated really effectively amongst the care team. Nick, I find that when you start talking to people, there's just so many that have these types of experiences within the healthcare systems. And again, just want to thank you for sharing yours. Now, Nick, I know you set out to solve these problems, not just based on your personal experience, but other opportunities you saw within Prisma with secure communication. Can you maybe talk about some of those other problems and challenges that you were setting out to solve?
Yeah, absolutely. Clinical communication, and this type of collaboration technology has changed so much in the last decade and a half. And, pager workflow is very, very two-dimensional, very limited functionalities, limit what you can do. Operators and nurses are constantly struggling to find out who's on call by look at their stacks of call schedules. And like as I said before, sometimes mostly on paper. There was no escalation process that was automated in any way. You called until you got someone, and you called again. And then what happens is the provider ends up with 10 calls and then try to figure out, did I already call that number, or is there someone else in that same number calling again? There was no broadcast groups where I can send out a message to everyone at the same time like you would as a surgical case from trauma or stroke or a STEMI patient coming in. So messages were being missed, and that obviously delays care. And in your circumstance, you can see when you don't communicate clearly how dangerous that can be. And so what we wanted to do is make sure that when we started to look at the CCNC technology is look at, how data flows, how the data comes from in and out of the EHR, so that it's not just a number or a text, it's context to it. Who you're talking about, what the patient is, where that person's located, so you don't have to ask all those things. So we also wanted to find out cloud solution that work for everyone at Prisma Health. It's not just nurses and physicians, but everyone across our system. Right. We needed a communication system that continued to adapt to the ever-changing, complex healthcare environment. As you know, the healthcare system continues to get more complex. And now you also have to think about not just taking care of patients in the hospital, but communicating to all the ambulatory doctors and caseworkers and care coordinators and pharmacists so that that person has a true 360-degree healthcare system taking care of them.
Yeah. No, so you mentioned pagers and you mentioned the telephone tag, and that's something I witnessed firsthand in my personal experience was the reliance on the pager. And, we've all moved well beyond the pagers now as a market, but surprisingly, Dr. Patel, I still see pagers out there in the wild. I was wondering if there's still any pagers at use at Prisma.
Yeah, we still have a spattering of pagers around Prisma also. It's kind of like a running joke. The only holdouts using pagers right now are drug dealers and doctors. And I guess we're kind of in the same business in some sort of way. But, I remember liking my pager in the fact that I had a separate phone number for that. So I didn't have to give my personal number out. But now with the technology that we're using with PerfectServe, with the application, it gives us a separate number. So when I text somebody, they get a separate number. Also, when I call someone, it's not going to share my cell phone number. In the beginning, we're all doing *67 and then the number so that our patients wouldn't have our cell phone numbers. But we don't have to do that. Also, with caller ID and everything like that, when you call the patient sometimes, even if it was from your cell phone, they wouldn't answer because it was an unrecognized number. But now we know through our, Cisco integration and everything else is that when the patient gets a call, it says Prisma Health on it. So it must be important, and the patient's more likely to answer it instead of thinking it's a robocall. And then the biggest thing is, you have to think about the integration within the EHR. You get so much more information in the application through PerfectServe than you do with just a plain two-dimensional pager. And that has been extremely important for us. And again, we also are able to know who looked at a page and not. And so then it auto-escalates. So you don't have to keep paging the people over and over again.
So, Nick, pagers and physicians and by the way, I love that joke. I've heard it before. The only two types of people left using pagers are drug dealers and physicians. But it's so true. Now, there's other stakeholders though across the care continuum. So in my personal experience, back in the day, doctors were on pagers, but nurses, for example, were relying on the desk telephone or even the unit clerks up on the units to convey communications.
Mm-hmm. Yep.
I just wanted your thoughts as well on the other stakeholders, right? We've got the physicians. I think we're down the road of largely solving those workflow issues. but then you've got other members of the care team, including patients and their family members. Did you have any comments on how a solution would need to address beyond just the provider, but into your other user bases as well?
Yeah, absolutely. You know, one of the things that I always that I use as my guiding shooting star is it has to be patient focused and provider driven. And what I mean by providers, I didn't say physicians. To me, nurses, care coordinators, PharmDs, they're all providers. And so we work very closely with our nurse leadership, right? At the time, we were looking at different ways to consolidate phone capability, texting, alarms on the units. We share devices. We wanted to reduce that trip time was very important to us. So you don't have to go from patient bedside to the workstation and back and forth to see if someone calls you. We also didn't want to end with the nurses to end up with a Batman set of tools around their belt, right? We knew that they had their personal devices, and then they have different devices that they use to give medications. They also have different devices that they use to round on patients. So we wanted to make it a little bit more simpler. So we decided a smartphone approach made sense for the nurses. We allowed both BYOD devices and have a fleet of shared devices. So if your device breaks down, not a problem. We have redundancy. You can use that. Maybe you have a device that doesn't have enough of a data plan, or you don't have the latest, greatest device, not a problem. We'll have a device for you. You know, the nurses don't really want to toggle between multiple different devices. They have enough things on their plate already. And we already had rolled out Vocera, our hands-free voice badges, to nurses in the upstate, and are in the process of doing that here in the Midlands. And so PerfectServe integrated seamlessly with Vocera, which was a huge win for the nurses. It also integrated into our Cisco phone systems. And while we started using mostly iPhone devices, it's important to have software solutions that also support Android, because that also is, as over the years, you'll just see that it's either iPhone or Android devices that are out there. So we wanted to make sure that they supported both. But we also worked with our informatics team. We wanted to see what our EHR vendor could do to meet our needs, out of the box. But unfortunately, the level of functionality and integrations that they offer just weren't there. Prisma Health, by February 27, 2021, will be on one instance of Epic throughout. Right now, we have Cerner in the Midlands, a spattering, some others, as well as Epic in the upstate. But after February, we'll be on one unified system. And also the EHR solutions, when we looked at them, were very, very expensive, and you got less bang for the buck for that. And as I mentioned before, we wanted redundancy, and wanted it to be cloud-based for reliability within our system.
That's great. Thanks so much, Dr. Patel. You mentioned something there regarding unification and simplifying, and a trend that I've been seeing and talking to our healthcare leaders is around their desire to reduce the vendor footprint. So I was on a call last week with a large East Coast system that had 1,000 apps in their ecosystem for clinicians, and they thought it'd be a huge win if they could just reduce to 500 apps by the end of the year. Well, as I've seen at Prisma and other health systems, I think there's just this huge opportunity to streamline the communication just by reducing the number of disparate solutions, right? When I walk into a hospital, I might see 5 to 10 different communication platforms that all have to be held together with duct tape and bale wire, right?
Yeah, absolutely.
Curious about your experience there and what you're seeing towards the desire for your constituents and your users to want to get there to a single platform.
Yeah, as I mentioned before, Prisma Health is a byproduct of Palmetto Health in the Midlands and GHS in the upstate, Greenville Health System coming together. And so you can imagine when you form the biggest healthcare system in South Carolina, bringing two large entities even separately together, you amplified the whole issue around different platforms, right? They had different EHR than us. They had a whole bunch of different legacy systems. And so that's one of the biggest things that we did is obviously as part of tech consolidation also saves the system a lot of money. not only does it do that, but also helps improve efficiency throughout the system. And hence, that's why we decided very early on that we would go to one instance of our EHR. As part of that project, we're sunsetting over 150 different applications as part of that process. That is a lot of money. So these legacy systems are going away. You would actually even have just one server doing one legacy task all day long that we don't need anymore. So it was very important part. And it's a huge expense to run all those platforms. And so the desire was to get down to a handful of strategic platforms and vendors. And more importantly than expense is the impact of care, right? So if you have all these different solutions, it impacts and delays care. So you have to start with communication. That is key. And it has to be unified throughout the system to drive efficiency. So that's why, one example of the telephone tag and pagers, we wanted to move away from that. And we wanted to make sure that from our online scheduling to when our doctors are on call, we knew no matter where you were, who was on call and for what subspecialty. And as we're moving towards one centralized command center for access, they also need to know. And it needs to be something that's real time. So anyone changes calls, and that happens every minute, it automatically gets updated, and everyone throughout the system knows who's on call. And the other thing was that we wanted to make sure we also took technology that was working so well in either region and expand that to an enterprise level, like our Vocera badges, which have been such a great addition in the upstate, expanding that throughout their system and also having those unified workflows around it.
Right. No, very interesting. Yeah, I've seen a big win with how we've been able to tie the multiple devices, both phones and the badges together. Thanks for that feedback. A big part, Dr. Patel, of the ability to merge and go down to consolidated platforms is integrations. As a product lead here for the company, I spend a good part of my time focused on how do we drive value out of integrations with the existing investments in the health system. I'm wondering if you have any particular thoughts on which integrations are key to Prisma, or which ones are more valuable than others.
Yeah, I think our philosophy is that first you really need to sit down to understand the lay of the land, right? You need to understand what are the key systems that we need and dependencies that we need to consider when you're mapping this out. So we develop a map of systems that we would either need to replace, integrate into our path for unified communications. Integrating into our Epic EHR was extremely important. That is our EHR first strategy, is to make sure that is the master record, and that's what we're driving towards. Then we had very important role-based integrations. For example, our nurses need integration, nurse call and alarm systems. We also had to integrate the system with our physician scheduling platforms. We had multiple platforms before implementing PerfectServe. We have people do not only multiple platforms, but still on paper. I mean, if you think about it, it's 2020, still on paper, still on Excel spreadsheets. So we needed to consolidate that and capture that. At the end of the day, most of our communication workflows involved some type of data or status from clinical systems. For example, notifying me that one of my patients has a critical abnormal lab result. So we're talking more about workflow than communication. That workflow is driven by integration. So if I get a critical lab result, I know exactly who's on call, who I need to call in the ER, if it's something that needs to be admitted or directly admitted, who's on call as a hospitalist. So it's all driven by that one, instead of me calling, okay, I got a critical potassium, I need to find out from the operator who's on call for the hospital service of this hospital. No, I could just do it right on my phone. And more importantly, I could text that person, and they could share that result and say, okay, I got you, I'm going to take care of it.
That's actually a super important point you're making, Dr. Patel, which is, with the example you gave, who should get that message is very contextual. And in my personal experience with the paging and telephone calls as a return medium, there was no way to know what the priority of, say, a phone call was, or even if your smartphone's in your pocket with normal text messages, no way to know the priority of those. Can you maybe speak to the importance of this type of workflow and deploying a solution or set of capabilities that actually takes the workflow into account?
Yeah, I really like this slide, Ben. It's amazing. Even though this is already complicated as it is, there's a lot of steps in between those arrows that sometimes have to occur. Every group and department has slightly different needs and, very different needs. And so one of the efforts we made was to standardize our communication workflows, directing the right communication to the right provider at the right time. And that is key. So you don't delay care and you drive, again, that efficiency internally. It gets very frustrating to a provider when you don't know who's on call and who you need to reach out to. Is also, bad for the patient, for patient care. You feel very helpless that you're trying to get something done, you can't get it done. So that flexibility is important because otherwise you'll have doctors being woken up and when they're not on call and nurses not able to find the right doctor. And that's happened multiple times. As I said before, I was a hospitalist, and sometimes, the way we do our shifts, we do 7 12-hour shifts in a row, and either day or night. And, you turn your phones off, you try to take a nap, and especially if you're coming off nights, and, you don't turn your pager back on, you get 10 different pages, then like, somebody's been trying to reach me. When they really shouldn't have been trying to reach me in the first place, is another provider. So this sort of logic and understanding, and you can imagine with the number of providers we have here at Prisma Health, how complicated this could become.
Oh, yeah. And another complicating factor that I've seen, Dr. Patel, is with teaching hospitals. So you all have GMH there and such high turnover, right, of the residence programs, and trying to keep everyone on the same page in that kind of context can be a huge challenge.
Absolutely. Yeah, we have 2 academic centers, physicians and nurses, pharmacists. So, yeah, absolutely.
So at the key of where communications need to go right now is the provider schedules. And that's a huge part of the workflow that we implement every day. And just wanted your thoughts on the scheduling challenges that a large healthcare system faces, especially with that diversity across your provider population with residence programs and many different locations. Yeah,
absolutely. It's a very, I don't even know how we used to do it before we had your solution, to be honest with you. Some of our challenges were creating fair and balanced schedules too for our providers. Schedules are taking a long time to create. And if you think about it, poorly balanced schedules means more back-to-back shifts and work-life imbalance for our providers, which contribute to further burnout. And with the large teaching aspect of our mission here at Prisma Health, as you said, Ben, residents come and go. They move from one rotation to the other. You may have one resident who is doing inpatient hospital service moving to dermatology the next or cardiology next. And, trying to make sure that we knew where they were going. But more importantly, the attendings who oversee the residents also change. And that attending may not be the same attending as who's taking care of primarily the patient. So it's definitely multiple different layers to this that you have to consider. And so we had, very different pockets of different scheduling platforms throughout Prisma, and partially due to just the different groups and different needs, they kind of had different ways of handling the complexity within their division, and that's what happened. But now we're all tying it into one master schedule.
You make a good point there as well with resident to attending. I know with a lot of the first line communications for patient care start with a resident that would get escalated to an attending if the resident is unable to respond. So what you just mentioned, which is residents flipping between locations and programs at such a high frequency, it must be pretty tough to make sure that the right provider gets that communication.
Yep.
So, Dr. Patel, just switching speeds a bit, because this is actually the first webinar or meeting I've been on in the last 6 months that didn't start with COVID-19. And, COVID changed a lot of things across healthcare, right? The rapid uptick in telehealth adoption and the acceleration of the consumerization of healthcare. And a lot of us don't feel like it's going to quite go back to the way it used to be. I can tell you from our perspective, I had 2 years of roadmap out there that we actually pulled in and implemented during COVID to connect the patients and their family members. I know you do a lot of thought leadership here, Nick, and you've been doing a lot of things at Prisma in this space, and just wondering what your perspective is for how COVID has changed healthcare delivery.
Yeah, it's been said that if there's any silver lining to COVID-19 is that we may end up with a modern day healthcare system, right?
Right.
And that's my hope, and that's where that we remain and continue to grow. But to your point, I mean, my 5-year and 3-year digital health strategy essentially accelerated into a 3 to 5 month digital health strategy, right? It's been great. The team has been working nonstop. We have a tremendous team, both in ITS and digital transformation teams, as well as our digital health teams have been working together with our leaders to keep moving the needle. And we had to pivot quickly to tackle COVID-19 challenges head on. We lessened the blow by ramping up telehealth visits very early on. And as you know, Ben, I'm a primary care doctor. After I was a hospitalist, I actually went into outpatient ambulatory medicine for the last 12 years. And we wanted to maintain the continuity of care by doing telehealth visits for our patients. We didn't want patients with chronic diseases, especially elderly patients, to exacerbate and end up in the emergency room. We didn't want them there, right? That's the hotbed of where COVID was. We initially focused on our patient with significant comorbidities. We put them that will put them at higher risk of death if they contracted COVID-19. And redundancy was key. As part of that, ensuring critical solutions like communication infrastructure can be managed in multiple ways, via both Wi-Fi and cellular was important. It was also very important in communicating to patients and team members about updates during this pandemic. If there's one good thing about COVID, it's there's standardized ways to handle it, from symptoms to treatment to follow-up. And in the beginning, with COVID, everything was changing so fast. It was very fluid. And, recommendations from the CDC and others continuously changed. And what we didn't want is an email thread to nowhere. We wanted to make sure that we had a centralized incident command center that where all communication first had to be approved before it was sent out. And we had different means of sending it out, either through broadcast groups to your platform or through email. We were able to operationalize our virtual health contingency plan in less than 1 week. And as of today, we've done over 360,000 virtual visits at Prisma Health. And it's amazing if you compare that to about 20,000 total last year. That's in the last 7 months. We've done 360,000 virtual visits. And we've also used this technology to reach out to patients. As you remember, the rules have gotten a little less lax and less stringent now, but you couldn't visit your loved one when they're in the hospital. Can you imagine both of our children being in, you couldn't visit them? We had to do that to prevent the spread of COVID. And so we wanted to make sure that we had that patient outreach from patient family members, and using your technology for video and texting communication was a very important part of that. So very, very happy with all the progress we've made. I think it looks like the payers, especially CMS, Seema Verma said this genie's out of the bottle. We're going to continue this even after COVID is done. And I really do hope that continues.
Yeah, you mentioned the ability to text family members and right from our core clinical apps is a key capability during COVID. And the reason why that happened, Dr. Patel, is we had 5 health systems ask us for that capability, all within the span of like several days. And for the very same reason, which is the hospital's on lockdown, caused a huge workflow problem for how communications cross the boundary of the hospital. And then as the clinic started to reopen, it was very similar. I think I told you this story as well, but the same week that we had so many requests to help these clinics reopen through a text messaging solution, I pulled up to a Home Depot and I had ordered a barbecue for my house and pulled into the parking lot, texted my number. They just threw the barbecue in the back of my car. And I drove off, and I turned to my partner. I said, "Why would I ever go into a Home Depot again?" And
right.
The same has to be said with the concept of a waiting room. I mean, the types of changes that we've seen over the past 6 months, I think, have quite a level of permanence to them, and I'm curious what you think about that.
No, I totally agree. I mean, I think we've all experienced our lives outside of the hospital system, hopefully, and that retail experience doesn't really exist in the healthcare system until now. So in order to deliver on that patient need, healthcare organizations have to change their strategy when thinking about the back-end systems to support consumerism. The systems cannot be siloed. They must exist as interconnected, ecosystem, efficient, intuitive systems that take advantage of automation. A lot of automation occurred for you to pick up that barbecue, so you drove up and you picked it up, and that's what we don't have, right? So you can imagine you having an appointment that you click online, you come up to a hospital system, they know you're within a certain geofence, you get auto checked in, you get to answer quick questions on your smart device, and you're checked in. And while you're waiting, because the system knows what kind of chronic diseases you have, maybe you start getting push notifications on education. Maybe you do a quick pre-visit consult with a pharmacist because you're paying way too much for your medications. So, leveraging data from multiple sources to drive the patient to the right avenue of care is very, very important. So getting a text from a nurse to a video visit or with a family or just even the patient, but also including the family is something that we really saw beneficial. I did so many telehealth visits during this time. The patients, number one, loved it, and they thanked me for it, that we had something that in place. But more importantly, I started to see major advantages in that I can have family members as part of that conversation. They can go to their cupboard and pull their medications out, and I can verify that they can. I actually had one patient take their smartphone and walk around their house, and I noticed the house was very cluttered, and I realized that's why she falls a lot. That's why she was a higher risk for fall and potential hip or back fracture. So you start to see them where they live. They don't live in your clinic. They don't live in your hospital. That's why we don't want them, right? We want to keep people healthy. You want to have that proactive care instead of having them get sick and then come to a health center. And that's where things are moving. And all these tools that you have on the screen help with that engagement, right? Remote patient monitoring that hits a certain threshold. All of a sudden, the automation behind the scenes going, hey, Mr. Smith's last 3 blood pressures are high. Let's set up a video visit right away. Why wait 3 months? Why wait 6 months before that person comes into your office? So communications is the hub and spoke piece of a lot of this technology we're deploying.
Hey, Dr. Patel, that was actually a really interesting example you gave. I mean, we talk about the benefit of face-to-face visits, which will obviously never go away, but your ability to actually view the patient, to meet the patient where they are and in their home, actually gave you insight and context on that patient you never would have had otherwise. So that's pretty compelling.
That's right.
That's pretty compelling. Dr. Patel, the reason why I started in the industry, and both of our personal stories are very similar, is with the sole purpose of improving patient outcomes. It's why I started my company. That being said, in today's very challenging environment, both financially as well, there has to be an ROI associated with making these investments. I was wondering if you have any comments on any of the ROI you've been able to demonstrate through going to a unified platform.
Yeah, it just makes me think of that movie, Field of Dreams. You build it and they'll come, right? Well, you have to
Kevin
build
Costner.
the right strategy.
Yeah, I love that movie.
That's right. Yeah, so you have to build the right strategy in order to reach these goals, right? We want to reduce our readmissions. So how do you reduce readmissions? Well, we need to make sure we communicate to that patient a little bit more after they leave through automation and texting, that we give them a remote patient monitoring device for congestive heart failure so I could see if their weight is going down or going up based on fluid weight, right? We could reduce length of stay if we just communicated better and we didn't have to have this lag time before we found out who was on call or when that next person is supposed to come in. So that, again, all these care delays and when getting a lab or a CT scan and delays that occur naturally over the weekend, they need to just dissolve away, right? If you do these sort of things, again, keeping the patient at the center of these things. Why are you doing this, right? You're doing it because you want to improve the care of that patient. Everything else just follows. Your revenue gets better because your length of stay is better. Your readmissions are less, right? Your workflow is if your workflow is good, you're spending time now seeing more patients and less patients. You're losing less providers because of burnout, right? You're automating a lot of these things. And if you make sure that you give them a good technology to use, they're not going to go try to use non-HIPAA compliant platforms, right? So all of these things kind of fit together. And it comes down to taking the robot out of the human. I was on AI Med conversation last week, and there's a great comment by Anthony Chang says, you got to learn how to take the robot out of the human. In healthcare, we do a lot of trivial tasks that drive us away from efficient care. This is what will help you achieve the mecca of quadruple aim, right? This means to think about automations and get rid of antiquated processes with technology. All the items, if you've listed up there, are something that we are working very close to achieving by choosing right technologies and consolidating it. And again, our partnership with you is foundational to a lot of those other digital health tools and other technologies that we're using because we're integrating that. And so having a CCNC partner that understands that and believes in your vision and where you're trying to get to patient care really helps move the dialogue.
Dr. Patel, I think we both feel the same way that this is a very personal mission for us, and we've talked at length about that. I just really wanted to thank you for sharing the insight that you shared with myself and everyone who attended the webinar today, as well as opening up with your personal story. I just want to close off. We're going to take some questions in a moment, Dr. Patel, but did you have anything else you wanted to add today?
Well, again, Ben, always great to talk to you. And first off, your daughter looks amazing, and as all children should be. And it's great to see you. My son is now 15 years old, 100 pounds, and can probably tackle me very easily. And, we're very blessed that both our children came through this. I'm sure we lost some years of our lives and grew some gray hair during the time.
Absolutely.
But, to me, it's what we do it for, right? I mean, we have to realize that is the core to what we do in healthcare. There's one absolute in life is that one day all of us will be a patient one day. And you have to realize what kind of care would you want to receive? How would you want that care delivered to you? And so exactly. I just always say this every time I talk to anyone who will listen is that start with the problem you're trying to solve and not the technology. And if you do that, then you'll be successful.
Yeah, I completely agree. And those were very harrowing times. And it's been largely my purpose for the past decade of my life. My 10-year-old here in the picture, Thea, she was the one with the feeding tube in the NICU that we started the session with. But yeah, she's 10 years old, going 10 years going on 16 years old right now, and and very healthy.
That's great.
Yeah.
That's great.
We'll look forward to connecting again soon, Dr. Patel.
Absolutely. Thanks for having me.
I've included our contact information, our direct emails, in case anybody here today would like to reach out to us directly. Again, I just want to thank everyone for spending their time with us today, and thanks for you and your frontline teams during this trying time with the pandemic. Thank you.
And thank you, Dr. Patel and Ben, for that fantastic presentation. We will now begin today's question and answer session. Please submit any questions you have by typing them into the Q&A box you see on your screen. We will try to get through as many questions as we have time for. So we already see a couple of great questions coming in from the audience. Let's start with this one. When removing pagers, how did you convince the providers that other technologies are just as reliable? What hurdles did you face?
Yeah, it was definitely a conversation. We really started by going to our leadership forums, our physician leadership forums, and having that conversation. And to my surprise, though, a lot of providers, have a love-hate relationship with their pagers. But luckily for us, most of them didn't like their pagers, and they wanted something more modern. Some of the surgeons and some of the folks in ER, wanted to keep pagers around. But over time, then they saw what the tool could do. They transitioned away from them. So some of them, it was a hybrid. They had both, and then eventually they moved to one.
Dr. Patel, another thing that I've seen work well is that for some period of time, the pager users would carry both just to get confidence that the solution is delivering right over a couple of months before they turn in their pager. I've seen that strategy work very well.
Yep.
Great. Thank you both for providing those details. So our next question is, do the perfect serve communications become automatically documented in the EMR? And how are prior perfect serve communications documented for future care team members and distributed to relevant interdisciplinary functions?
Yeah, Dr. Patel, I'll start with that because it's a very product-focused question. But yeah, absolutely, we allow for the archival of specific conversations to the record. But what's interesting in that is that, and what's really important is that clinicians have a lot of communications which they don't necessarily want every piece of to be on the record because it can actually slow down care delivery. So it's a selective capability in the product. I think I answered that question with respect to documenting back to the medical record. Other alternatives are that history is just kept in a searchable archive in the platform for discovery when needed. So there's discovery in the platform, but there is also the option to put specific back to the EMR. And in things like delivering critical results, we actually integrate directly into the flow sheet for those workflows, in some cases into the major EMR platforms is one example. Yeah,
just to add to that, Ben, totally agree. The EHR is already bloated as it is with documentation that is required as part of the system. We didn't want to have everything go in there. And you also have to remember that your EHR is still your master record. So if you're still having a communication to that patient, you have to escalate something. The orders and everything else and further imaging, whatever else you're going to order is going to happen through the system. So there's going to be documentation as part of that workflow. As the provider is going to go see the patient, and the nurse is going to say, okay, I talked to Dr. Patel and he's ordered X, Y, Z. She's going to make a notation of that. So it doesn't need that every single text and everything correspondence has to go through and be as a matter of record within the EHR. But as Ben, you said, is archived as part of the system. So if you're ever going back trying to figure out where someone you have an HR complaint, even you can pull that up and say, okay, here's where things went wrong. You can also pull that up. So, yeah.
Great. Thank you both for clarifying all of that for our audience. So our next question is, does the EMR directly communicate the critical potassium you just described via Perfect Serve, or is the RN or lab still required to enter the message to the physician?
Yeah, it's the beauty of the system. It comes directly into the platform, and it tells you the patient. It gives you context, who the patient is, their MRN, their date of birth. It gives you, that's part of the EHR integration. It tells you the potassium result, and it gives you a callback number, so you just simply click that and take the next step. So if it's on the ambulatory side, you're obviously calling the patient to do X, Y, Z. If it's on the acute side, you have a patient in the ICU, you see high potassium, you're getting the callback number to the nurse and to do the next steps. And, you're going to find out if that potassium is real or not, is it hemolyzed or not. You can go through that process through that. And you can next, I've done that before. I get critical potassium. I'll text back, says, is it hemolyzed? And I go, no, it's not hemolyzed. So then I can then say, okay, so that's a true result. And do something with that, with collaborating with my nurse.
Awesome. Thank you so much. Our next question is, how long, how many months, years, et cetera, did it take to streamline the communication technology within the hospital system?
Yeah, Ben, I could take a first shot at that because we're going through that right now. Yeah, because we're, the good news is when we were not Prisma, the Greenville Health System as well as Palmetto Health System both were working towards having telematic by Perfect Serve. So now what we're doing is taking that into one enterprise system and integrating that into our one EHR Epic. So that process has been ongoing, and it takes. And we also decided to bolt on Lightning Bolt, which is their complex scheduling tool. You can do most of the scheduling through the application, but for those very complex schedules like hospitalists or cardiologists that are, taking 6-hour shifts or 8-hour shifts and then do days and nights, or they're going to the heart cath lab, or they're doing ambulatory, or they're doing etiology one. All of those different complexities can be put into that and driving that logic into who's on call. So we're doing both the enterprise rollout as well as the integration of Lightning Bolt into our system, and our go live date is by the end of the year. So you're looking at about 4 to 6 months to do all of that. Might be longer for others just because they may not have it originally, but we already had it, so this is more fine-tuning it for an enterprise level.
Yeah, that's right. And we also talked about a lot of workflow today. So health systems can typically get up and running very quickly. You're looking at maybe a 4 to 6 month project typically, but then you can have a strategy by which you layer in the relevant integrations once the users are comfortable with the medium, and that's one of our approaches to get quick wins, if you will, and then to drive more value as time goes on.
Thank you both. That was very helpful for our audience to understand. Please answer a couple more questions. I have one for Dr. Patel. As you think back on all these advances your organization has made with communication, what advice might you give to others who are just beginning a similar overhaul?
Yeah, I think starting with understanding of your current footprint. What are you using? What's working? What's not working? But start with having your providers at the table and getting a download of all the issues that they faced. And your IT folks also need to be at that table so they can understand, what it's going to take to deploy it, what systems it's going to work well with, and some things that it's going to be a conflict. So it's always, again, important to understand what are you trying to achieve. If you're trying to achieve a unified communication platform across the whole healthcare system, well, you want to involve providers from different disciplines and different divisions because everyone's workflow and their needs are different, right? I'm a primary care ambulatory doctor. My needs are a lot different than a trauma surgeon's or a cardiothoracic surgeon's or an ER doctor's. And so understanding those nuances is very important. And it's not that you have to form a different workflow for each one, but you'll start to notice what are the key ingredients that you need for deployment. And then working closely with your vendor and understanding, okay, here's what our needs are, here's where we want to go roadmap-wise, as Ben mentioned. You grow it over time, phase it in so you don't delay it. Don't let perfect be the enemy of the good. Try to get to that eventually, but try to hit your high priority items first and sequence out the development for growth later. So that's where I would say is, pick the right vendor, do an RFP, make it sure you understand and have what EHR integrations you need, but look closely at the vendors. There's a lot of vendors that'll say they have a check mark for clinical communication collaboration like EHR companies do, but when you start to look under the hood, they only hit the surface of that. If you truly want something end-to-end, you really need to do your homework.
Awesome. Thank you so much for all that great advice. We have another question here for Ben. You all talked about rapid adoption of telehealth this year and how roadmaps changed to accommodate it. What's next? What else is needed?
Yeah, so we're at a crossroads here with respect to clinical communications of actually having what used to be the vertical known as patient engagement and clinical communications coming together. You'll see that through integrations, but you'll also see it through vendors that can provide all those communication capabilities. So the merging of the clinical communication domain with the patient and family communication domain. And what that really looks like from a day-to-day basis is actually having the family as part of the care team in the applications as part of the process in caring for patients. And then the other area that we're focusing on is within a healthcare systems, what we refer to more generally as the digital front door. So when a patient, for example, lands on the healthcare system's website and they start interacting, Dr. Patel didn't talk a lot about it today, but there's a whole consumerization experience of it launching, for example, a chatbot. Well, it's great to be able to have that kind of consumer experience, but in the back end, where those inbound communications go can be a pretty tricky problem to solve, and we're focused on solving that right now within our solutions.
Thank you so much, Ben.
Yeah,
I'm sorry, Dr. Patel, go ahead.
I want to give Dr. Patel time to react to that. Yeah.
No, I mean, it's the digital front door and just overall digital transformation is, at the heart of what we're trying to do here at Prisma Health. One of the first things we did when we became Prisma is have an online scheduling ability for patients, right? We updated our websites, we updated our provider directories, we had the ability for online scheduling. But we also, during the COVID period, introduced automation through chatbot and had 110,000 people interact with our COVID chatbot. We used that chatbot for screening for people in the community. We used it for our own employees to have a digital badge that they're clear to come to work. We also provided it for folks who wanted to return to work, an automated way to get a letter from your provider that said you're good to go to work. So I think that it's all about, again, connecting the dots. How does an automated chatbot escalate you to the right avenue of care based on input coming through a wearable device that says, this person's getting into trouble, let's set a video visit up, let's get a care coordinator to the house, let's get a nurse to their house, preventing that hospitalization because you caught it early. And then having devices even that we have partnered with, the company Untitled Care, that you could do a remote physical exam. So I can look at your leg for edema, listen to your lungs. So I'm able to do more that I could. Technology really enabled us to be able to do more out of the office than in. And but it's all important to put all those pieces together so that you're not working in separate solutions, but one continuous digital continuum.
Absolutely. Thank you both so much for those responses. And that is all the time that we have for today. I want to thank Dr. Patel and Ben for their excellent presentation and Perfect Serve for sponsoring today's webinar. Enjoy the rest of your day, and we look forward to having you join us for future webinars.